Hello, everyone. I'm very happy to be part of this year's Asia-Pacific HIV Clinical Forum, and it's my role in this interesting session to provide a pharmacological perspective when choosing an antiretroviral treatment. So one of the first things I thought would be important to do is to highlight what I think are the key pharmacological factors that influence any decision when thinking about treatment. The first one is formulation and dose. Nowadays, we have many fixed dose tablet formulations of different sizes, and this can still be a factor for certain patients, particularly adolescents or young children, and more so even for some elderly patients. So that is still a factor. And obviously, how many times you take the tablet a day is also a factor. Today, we have once a day tablets and even longer than that. But again, we have to take this into consideration when thinking about a regimen. But the main one, which I'll talk about a lot today, is polypharmacy. And this is really to do with drug-drug interactions. And that can be either through co-medication, perhaps in elderly patients that they are taking, or as often in the case in our setting is co-infections such as tuberculosis or hepatitis C. So treatment of TB or hepatitis C combined with antiretroviral therapy can be quite challenging. Thirdly, just general comorbidities. Again, these could be specific for the kidney or the liver, where these have impairment. Therefore, the choice of drug, etc., maybe have to be amended, the dose or the dosing schedule. So again, this has to be considered. Of course, in pregnancy, now all pregnant women are treated. We need to think about specific populations here in terms of when to treat during the postpartum treatment, during breastfeeding. And also, of course, in neonates and children are a very challenging population to think about when giving antiretroviral treatment. So all of these factors together, what I'm going to try to overview and for you to think about when you consider choosing an antiretroviral regimen. So here we just have I just put up one slide of the review of the guidelines. I know we've had a very nice talk earlier of the guidelines in Asia, but I've just put up the US, the WHO in the middle, and Thailand on the right, just to highlight perhaps some of the key differences, and we'll try to tease out some of the pharmacological differences. So if you look at the US on the right, and in green, we have primarily integrase inhibitors is the anchor drug, where DTG and is for the WHO, and Thailand is the anchor drug DTG. But then if you look at the backbones, you have TAF, FTC, Abacavir for the US, but specifically TDF for the WHO and Thailand. And when you look at the second line in WHO and Thailand, we're primarily focused on the orange, which is our NRTIs, while in the US, they focus on even other integrase inhibitors first, perhaps NRTIs and some boosted protease inhibitors. So when we look at the differences, we can see that there are differences in terms of perhaps the choice of TAF versus TDF. Also, 3TC versus FTC is a very common choice, and the different types of integrase inhibitors. Primarily, we are using in the Asian region DTG. So what I thought out when I was thinking about this presentation, I thought I tried to tease out again, like I say, the differences between different choices. So what is it, from a pharmacological perspective, the difference between TDF and TAF, 3TC, FTC, and specifically the integrase inhibitor? Well, we know most of it on DTG, but it'd be interesting to know how it compares to the other integrase inhibitors. I'll also touch on a little bit about specific populations, such as TB co-treatment and in pregnancy. And I'll end on just one sort of interest of mine, which is thinking about drugs when we're thinking about the HIV reservoir, which is not really yet used for the choice of regimen, but perhaps in the future we can think about that would be an interesting factor. So let's start with TDF versus TAF from a pharmacological perspective. And actually, as you know, it's probably the choice of this is why they give you choice, is probably sort of limited by the fixed dose combinations that are available. While TDF was, it's been around a long time, since 2001, and TAF, perhaps since less so about 2015, there are individually, formulated, specifically more so for hepatitis B treatment. But for HIV, they're primarily co-formulated, such as TDF-FTC, Truvada, or TAF-FTC, Descovy. And these choice of the fixed dose combinations, but they are still just, TDF swapped out for TAF, which is with the Complera, so TDF-FTC rilpivirine. Now there is an equivalent TAF-FTC rilpivirine. So again, the choice, primarily within the fixed dose combination, you can swap out the TAF versus the TDF if that different formulations available. But I have highlighted on the bottom left here the TDF 3TC DTG regimen, or TLD, which is primarily going to be used, or started to be used across Africa and across Asia, where there's high burden of disease. So again, we're focusing on that, but I want to look at the differences. So when we think about tenofovir, we have to be very careful sometimes about the three-letter word we use, TFV, TAF, TF, or TDF, et cetera, because they are going to be, when we're thinking about pharmacology, quite different. So here we have a picture of the actual TFV, which is the drug that they originally showed that was going to be effective, but when they tried to give it as an oral formulation, it was unable to be absorbed across the GI tract. So what they did is they produced a prodrug called TDF, and here you can see chemically they just attached a chemical moiety on the end to stabilize it. So that's tenofovir diproxylafenamide, which is then, once you stabilize it, it was able to cross the GI tract and be absorbed into the systemic circulation. And that's what has been primarily used since 2001. And then more recently, they've just slightly tweaked this prodrug to TAF or TAF, or tenofovir alafenamide fumarate, where they've just swapped out this sort of prodrug from the ester to an amide. So when we think about TDF, TFV, TAF, and TFV, TDF and TAF are basically just different prodrugs of TFV. So that's important when we think from a pharmacological standpoint, because for both drugs in the plasma, we will be measuring TFV, whether it came originally from TAF or TDF, and sometimes that can be a little bit confusing. Hopefully on the next slide, it will be a little bit clearer. So here we have on the top of the slide, a little bit of a schematic of where tenofovir, the top one, TFV, like I said, if that is given just orally, it just does not be absorbed across the GI tract. So that's why they made the prodrug, the second one, TDF, which is 300 milligrams, quite a high dosage. But then when you give that orally, it can cross the GI tract and enter into the bloodstream and into the plasma. But when it enters into the plasma, it's immediately hydrolyzed into TFV. It says on the slide there, TDF, the half-life is around 0.4 minutes. So very difficult to measure TDF in the plasma. So when we take TDF, we're focusing on TFV in the plasma. And then actually when it's absorbed, it goes from the plasma into its target cell. You have TFV here in the red square, and then that's transformed from tenofovir monophosphate to tenofovir diphosphate, which is then its active form, which is then used to inhibit HIV transcriptase. Well, thirdly, looking at TAF now, you see TAF, 25 milligram, very different dosage compared to the TDF. And here, this time when it can be absorbed against the GI tract, but this time it does not get hydrolyzed. It actually, TAF continues all the way through into the target cell, where once it's inside the cell, cathepsin A will then metabolize it or hydrolyze it to TFV. So both drugs, at the end of the day, are producing TFV inside the target cell, which is then, as for TDF or tenofovir, it comes into tenofovir diphosphate again. So TAF really, when you look at it, it's really just a more stable in blood than tenofovir, and but nevertheless, you still get some lower levels of tenofovir. So when you take TAF, you still can measure tenofovir in the plasma. It's a much lower level of the tenofovir you would get with TDF, but nevertheless, it's still there. So that can be sometimes confusing. And this lower level of tenofovir with TAF is advantageous. I'm not going to go a lot into it in this presentation because we're focusing on pharmacology, but these low circulating levels of TAF compared to the levels you get with TDF are very important in terms of risks of bone and renal toxicity, because you do not have this TAF or high systemic concentration of TAF circulating in those organs and perhaps giving some side effects. But again, for these drugs and NRTIs in general, we really want to look at the intracellular levels. And here, this was a nice study, very clearly states the difference from a pharmacological perspective, is that your TDF, 300 milligrams, or TAF, 25 milligrams, given as monotherapy for 10 days. And on the left here, as I said on the previous slide, when you give TDF versus TAF, this is the concentration of TFV in the plasma, or tenofovir, and you see much, much lower levels of tenofovir in the plasma. But importantly, and it switches when you look inside the lymphocytes or the PBMCs, you see much higher levels of tenofovir diphosphate compared to when you get with TDF. So that is very interesting, because this TAF formulation is much more stable, and it can promote the delivery of tenofovir TFV, into the lymphoid cells. And when on the right-hand side, it's just looking at the different virological response, which is very similar. So again, just to highlight on the bottom of the slide here, that TAF really, from a structural standpoint, it really just allows enhanced delivery of TFV into the lymphoid cells, which then can be transformed into tenofovir diphosphate. Here's a slide just to directly compare some of the pharmacology between TDF and TAF. Again, not going to go through all of it. I thought this would be a nice reference slide for those later on, but TFV is metabolized into tenofovir, and then that is renally eliminated through glomerular filtration and active tubular secretion. That's quite a long half-life, no real protein binding, and when it comes into it being an inducer or inhibitor of certain drug transporters or metabolism, enzyme metabolism, they are not really involved. A key factor here on the left is the renal impairment. When you get to low renal impairment, because it's eliminated through the kidney, you will have to do some dose adjustments or giving it less frequently, and there's no real food effect. While you look at TAF, again, we're looking at TAF itself, again, we don't have to get confused. That's hardly really excreted unchanged. Actually, it does not hang around a lot in the plasma, goes quite quickly into the lymphoid cells. So the half-life of TAF is actually 0.51 hours. So if you give TAF, even though it's given once a day, if you looked for TAF in the plasma after maybe 10 hours, it's very difficult. It's very low levels. You can still measure the TFV, but not the TAF. Again, for TAF, it's quite high protein band compared to the tenofovir. But in this case, for TAF, there's two pharmacological factors you need to take into account. There's this, there are quite strong substrates for drug transporters, efflux drug transporters. And again, when we're looking at the renal impairment, there is actually quite an interesting difference. And this is where you have to be very careful when looking at whether it's TAF alone or TAF as part of a fixed dose combination, because TAF by itself, it can be actually prescribed in individuals quite severe renal dysfunction. But when it's part of a fixed dose combination, we have to be a little bit careful because obviously FDC is in there well, or 3TC as well. So the threshold or target of creatinine clearance might be different whether you're giving it alone or as a fixed dose combination. So that's something that you have to be wary of. So TAF, this factor, the TAF, which TDF does not have, but TAF being a substrate for these drug transporters can be a bit of an issue. And for example, with rifampicin, which we know is primarily everybody knows it is an inducer of the cytochrome enzymes, but it also is an inducer of some drug transporters, and that can have an impact. So here we have TAF with rifampicin in healthy volunteers, and you can see in the plasma, remember we're looking at TAF first, TAF plasma levels go down by about 50%, tenofovir levels go down by about 50%. But again, with NRTIs, we're more interested in the intracellular level. So there was a very nice study looking at this as well. So again, instead of looking in the plasma, they're now looking in the PBMCs, and now they're looking at the tenofovir diphosphate, so the active moiety. And on the left here, you can see this is the levels you get with TAF intracellularly alone. And then when you give it with TAF rifampicin, they sort of reduce a little bit. So you see there is an impact of rifampicin, but however, what's important again, when you compare those tenofovir diphosphate levels with rifampicin and TAF versus just TDF alone, you're still well above what those are achieved with TDF, sorry. So you have to be thinking, well, from an intracellular level, these levels should still be quite efficacious. But we have to really think, I think from a pharmacokinetic standpoint, they look quite reasonable, but I think there's still some uncertainty about, we need to have some clinical data on the virologically and, other clinical factors before, saying that these two drugs can be given together. A quick note again on 3TC versus FTC. Again, they're very similar drugs. You can see from the structure, very tweaked slightly, but as an NRTI. 3TC and emtricitabine shown here. Again, I won't go into too much of the details, but we know 3TC is twice daily or once daily, whereas FTC is once daily. They're both not metabolized. They're both eliminated unchanged through the kidneys. Similar half-life, protein binding is very low. I think for hepatic impairment, no problem, as you would expect, because it's renally eliminated through the renal pathway. But this is where we have to be a little bit careful when you have 3TC versus FTC. There are, again, little differences when you think about these fixed dose combinations versus alone. So, for example, if 3TC is part of alone or part of a triplet, they have a creatinine clearance limit of 50, but when it's part of Triumeg, it's lowered down to 30. So again, just be careful when you're thinking about giving a fixed dose combination of 3TC or FTC with other drugs, and you have someone with renal impairment, just be careful about the threshold where you may have to do some sort of adjustment. Moving on to the integrase inhibitors, again, dolutegravir is going to be the one that you will be most familiar with and be using over the next few years. But it'll be interesting to compare how that pharmacologically matches up against, the older integrase of raltegravir and L-valtegravir and the newer one, bictegravir, which remember was the first line drug in the US. If we look at the integrase inhibitors in terms of their pharmacology, again, this is a very detailed table, but I hope that it's will be used as a reference for you. You can see all of them are once daily apart from RAL, which can actually also be twice daily. Some of the drugs can be given twice daily in certain clinical situations, such as resistance or with TB medications, and we'll come on to that. But looking at the pharmacology again, you can see DTT and RAL are primarily UGT1A1 metabolized, while L-valtegravir and BIG are primarily the cytochrome 3A4 pathway. And these are important because then the induction and inhibition of these specific enzymes will cause certain drug-drug interactions. Their half-lives are relatively similar, apart from L-valtegravir, obviously, which is very low when it's given alone, and this is why you have to give it with a pharmacoenhancer like ritonavir or colchicistat. Very high protein binding, no problems with hepatic impairment, although it hasn't really been studied, any of them, in patients with severe hepatic impairment. And for the renal, no major issues as we saw for 3TC and TAF and TDF, but bictegravir has a recommendation at a lower level. So they are quite similar, but one of the issues across the entire spectrum of integrase inhibitor is when you give it with divalent or trivalent cations. And this is quite interesting because it's sort of unfortunate that the way these drugs work in terms of its mechanism of action, they have been developed structurally so that they can bind magnesium cations, because when it's in terms of its inactive site of the HIV transcriptase, it needs to bind to these magnesium cations to have its antiviral effect, to block the HIV integrase or the integration. So that's a very important mechanism. So when these compounds, which are designed to try to bind to these kind of cations, and if you have cations in the GI tract, which is quite common when you have antacids or mineral supplements, it will bind to the integrase inhibitor, and then actually at that point, it will actually block it being absorbed into the systemic circulation. So this is why we have to be a little bit careful when giving these drugs, integrase inhibitors, with different types of cations. So, for example, here, this is a nice study just looking at DTG or dolutegravir with calcium carbonate supplement or iron supplement on the right. These are concentration time curves. I know there's many lines, but I think you just want to focus on the bottom line, which is the red line, which is when dolutegravir was given either with calcium or ferrous cations in the fed state, and you can see the levels are much lower than when not. So, and they're decreasing by about, you see here, 39 to 54%. So that is a significant factor, but you can overcome this by giving it early or giving it later, or with food. But again, you just have to be very careful when giving these drugs, because we have to think about what is the clinical significance of that. This is quite addictive. Does that cause a clinical factor? And before I talk about this slide, I just wanted to mention, I have read recently a clinical case report of someone who was just suddenly taking zinc supplements, who were on bictegravir, and they actually had a viral blip. And I think there's many other case reports in the literature where saying when they were looking for these viral blips, and when they looked back, it was because of some supplement that the physician was unknown, that didn't know that they were taking. But I selected this study specifically because it was done in Taiwan, and it's looking the use of dietary supplements and polyvalent cations and antacids and the impact on viral load of those who are on integrase inhibitors. And this was quite a large study of 500 patients on ART, and they had around 60% on supplements, only around 7% on antacids. But in their multivariate analysis, might be a bit small on the screen, they showed that there was a higher risk of, or there was an association with the risk of viral replication, or becoming non-virally suppressed if you are on antacids. They didn't see it for the supplement, but again, it might depend on the type of supplement and the type of integrase. But again, so there is perhaps a clinical consequence of when these are given with cations. And I put this table up, and on the next slide, another table, just looking at the complexity of the different types of cups. And I'm not going to go through, but I think that I found this on the Liverpool Drug Interactions website. It's very nice, and it goes, for example, the one I've highlighted, dolutegravir, whether it's a calcium or magnesium. Again, there might be different guidelines in terms of how to give them. Similarly, for the antacids, again, be careful if it's an aluminium magnesium antacid or calcium antacid, there may be different recommendations. So again, we have to go one by one to have a look at how they are impacted. Looking at TB medications, I just wanted to touch on this because, again, for dolutegravir, it's going to be widely used. Rifampicin in use in Asia will be quite widespread for TB treatment. And actually, they've actually come up with a nice dosing alternative. We know, dolutegravir is 50 milligrams once a day. And rifampicin is a strong inducer of UGT1, which metabolizes dolutegravir. So an idea was to give it 50 milligrams twice a day, which you see on the left-hand side of the graph here. You see that the graph shifted up. And then when you add on rifampicin to this 50 milligrams once a day, the double peaks drop down, and it sort of overlays with the 50 milligrams once a day. So this, looking at it from a PK perspective, said that, okay, if you use dolutegravir with rifampicin, it can help overcome the interaction with rifampicin. So that would be the recommendation for dolutegravir. But however, I just wanted to quickly show this. For bictegravir, they tried exactly the same, although an integrase inhibitor metabolized this time more by CYP3A4, but doubling the dose in this type with bictegravir did not overcome the interaction with rifampicin. So this is why it's very, differences between the integrase and, able to predict what the drug interaction will be can be quite difficult. Next, I'm going to touch onto the physiological changes during pregnancy. These can happen because of different changes that can affect absorption, drug distribution, metabolism during pregnancy. And therefore, we're not sure if the normal dose, which you give to non-pregnant adults, can be given to pregnant adults. So we have to study this. And looking at the drugs that we have in terms of dolutegravir and raltegravir, the integrase, they have been studied during pregnancy, and we're seeing around about a 30% decrease during pregnancy. The green line here is the concentration time with postpartum, and these are either the second or third trimester. And you see there is this decreases, and we see that it may be lower, but then in terms of virological response and other data, they've decided that or interpreted that this dose reduction or no dose reduction is needed, and these changes are not significant to warrant a change in dosing for both dolutegravir and raltegravir. Bictegravir data is being collected, so there's no information on that yet. But things can be important during pregnancy. We've known for L-valtegravir, cobicistat, and for darunavir, cobicistat, atazanavir, cobicistat, they have significant reductions during pregnancy compared to non-pregnant situation. And this is probably driven by the significant reduction in cobicistat concentrations, which is then leading to reductions into either the L-valtegravir or darunavir or atazanavir. And now these, because you've seen these differences during pregnancy, the FDA now does not recommend cobicistat during pregnancy. So again, we have to be careful. We have to look before which drug is selected to know which one to use during pregnancy. And finally, I just wanted to go on to one pharmacological considerations in the cure strategy. This is not really for today, but I just thought, if we're thinking about the choice of regimen, what would be in the future? What do we need to do to try to have the ideal regimen? And these are drugs which perhaps will be able to penetrate the reservoirs where there may be latently infected HIV-infected cells. So this was a nice study done recently, just published this year, looking at lymph nodes in Reese macaques, which were looking at the distribution with using this new imaging technology to look at where the drugs are in the lymph nodes, where do they penetrate, how do they overlap. And again, I think, although this is not for today, I think it'd be very exciting to know in the future if we can design drugs or look for drugs where they would target specific reservoirs, or you use this drug, say, I would like to use this drug because therefore we can make sure we get enough drug in the lymph node, et cetera, et cetera. So again, this is just something I popped in at the end just to stimulate the ideas that the considerations I've mentioned, but hopefully in the future, we will look to have more targeted therapies across the whole compartments of the body. So in summary, I just want to say that obviously there's multiple pharmacological factors that should consider when choosing an AV regimen. I've repeated the nice schematic on the right. Understanding a little bit about the basic pharmacology will help. If if it's renally eliminated or through the liver, we can expect or predict some drug-drug interactions. Special populations, pregnancy, I haven't talked about neonatal children, but again, we have to think about special dosing and for these populations and whether these drugs can be used or not. And looking forward again in the future, clearly we need to have perhaps different drugs, different target mechanisms to target different compartments of the body, which will then be perhaps in the future be used, and that would make your decision to choose that specific drug. And with that, I'll stop. Thank you.